Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, and today I'd like to have a discussion about neurosurgical emergencies, or rather, pediatric neurosurgical emergencies, with the pediatric neurosurgeon from the Children's Hospital of Colorado, Todd Hankinson. Thank you very, very much, Todd, for coming on the show. You're a neurosurgeon, probably the busiest type of doctor, so I appreciate your time and I appreciate you coming on the show. Let me just introduce you to the PEM Rules listeners. Todd is originally from Albuquerque, New Mexico. You went to medical school in New York City at Columbia, and that is also where you did your general neurosurgery residency. I don't know how, but during medical school, Todd also got an MBA at the University of Oxford. Todd, you're going to have to do some explanation there in England. And then you did your pediatric neurosurgery fellowship at the Children's Hospital of Alabama. You have been a faculty or an attending at the Children's Hospital of Colorado since 2010. Is that right?
That's exactly right. Yeah.
Did I miss anything?
No, I don't think so. That's about as interesting as I get.
So explain to me, because I know a lot of people who have an MBA and it's an extremely intense degree. How did you do an MBA during medical school?
So the dean at Columbia was really supportive, and I just took a year off and was able to, the program at Oxford was nice because they condensed it into a single calendar year. And so I went over there for a year and did the program, and then came back and finished up my rotations as a fourth year med student.
Impressive indeed.
Yeah, it was really interesting.
Well, again, thank you very much for coming on the show. And my first question to you, Todd, again, it's a question that I ask all my guests on PEM Rules. What is your definition or your description of a good PEM physician or PEM clinician, one who does what?
Yeah. Well, that is a good question. So I'm glad you asked, everyone. And I just want to thank you also for having me on. It's fun and it's an honor. And so I appreciate it. I think that it's interesting. Like, I feel like PEM physicians, it's almost in some ways like the opposite of neurosurgeon, in the sense that I only have to know this super narrow, tiny little bit of stuff. Whereas you guys are tasked with knowing so much more and being able to identify things without any prompts or, starting off with imaging or anything. And so I feel like a really good EM doc can identify when something is life-threatening or is a critical situation really quickly and figure out how to manage that and tease that away from things that are a lot less acute and urgent, and can potentially be managed at a different cadence. And so I think being really skilled with laying out a broad differential and being able to tease things off of that list really quickly, and then being able, depending upon your practice environment, to interface with specialists and speak their language enough that you can effectively communicate and take care of the patient together. Or if you're in a situation where you don't have them like in the building, be able to do the first couple of steps in managing people with many, many different clinical situations. So I think that those are really the big things I think about that probably make an EM doc really skilled.
All right. Well, thank you very much for the compliments. I don't think of my job or my field is very complicated versus a neurosurgeon who has to operate on children's brains. But thank you very much for the compliment. I appreciate it. We appreciate that. My next question to you, Todd, has to do with probably one of the most common neurosurgical emergencies or neurosurgical presentations that I see as a pediatric emergency doctor is the child who has some kind of shunt, usually it's a VP shunt, coming in with headache or vomiting with an obvious concern of a shunt malfunction or a shunt infection. In Pittsburgh, in fellowship, I certainly saw those kids very often, less so in Florida and here in Vegas. But as a Peds emergency doctor, over the years, I adopted or developed what I call the red flag theory. So every chief complaint has some red flags that I, as a pediatric emergency department physician, must recognize. So, for example, a good example is always the child with abdominal pain. If it's right lower quadrant, that's a red flag. If the patient or the child can't jump, and I think they have peritoneal signs, then that's a red flag. And in my fellowship in Pittsburgh, one of the things that I learned from the neurosurgeons was there are some red flags or some important questions, rather, that a child with a shunt has to be asked, or the parents have to be asked. And I have that list. I want to share that list with you and get your opinion about it.
Yeah.
So again, I was taught in fellowship that every child that I see with the shunt who I think has a shunt infection or a shunt malfunction, the 6 questions to ask are reasons for the shunt insertion. I was told that kids with myelomeningeal tend to have more complications and do a little worse. Number 2, what is the date of the last revision and the reason for the revisions? Number 3, head circumference, if it's applicable. Number 4, fontanelle tension, again, if relevant for the patient. Number 5, to check for evidence of CSF dissecting along the shunt tract. In other words, is there any swelling where the shunt goes in the neck, etc.? And any seizures or change in seizures should be asked about. And again, that's a red flag. Do you agree with that list? What else would you add to it?
Yeah. Well, I mean, I think first of all, the pediatric neurosurgery group in Pittsburgh is outstanding, and I think that they did a good job helping to communicate some of these things, which is not unexpected at all. Yeah, I think that is a really good list of things to look for. You know, I think just starting with the first one, with reason for the insertion, and myelomeningocele is a really interesting dynamic area of hydrocephalus treatment right now, and I think that knowing the reason the patient has hydrocephalus is really critical. And with with mylos, you know, the reason is historically the majority of patients with myelomeningocele were closed postnatally, so after they were born, and they needed to get their shunts very early on. And the theme of kids who are shunted very early in life being fairly dependent on their shunt and potentially having dramatic symptoms when there's a problem is really important. So almost every myelomeningocele patient falls into that group. The patients who are closed postnatally almost always have a Chiari-2 malformation, which involves significant herniation of the cerebellum into the cervical spinal canal, sometimes brainstem as well. And so there can be brainstem compression that can get exacerbated when they have a malfunction. And so that can lead to things that can make you acutely ill and be acutely life-threatening, like lower cranial nerve dysfunction, respiratory compromise. And I think that's where the myelomeningocele patient potentially being a red flag patient really comes from, is they can have these really dramatic presentations. One of the things that's really interesting in that area right now is with the advent and popularization of in utero repair, we're seeing a lot of myelomeningocele patients who don't have a Chiari-2 malformation. And as a matter of fact, many don't end up needing shunts, but when they do, and they don't have a Chiari-2, I think it'll be interesting to see if they're a little bit less likely to present with acute life-threatening lower cranial nerve type symptoms than people historically had been. And so it'll be interesting to see over the next generation whether that evolves and whether you see it in the kids who are closed in utero versus postnatally. The majority of kids are still closed postnatally. So I think that it's going to take some time to tease all this out. But that's certainly one of the really good questions, is why is the shunt there? You know, the other group and the most common reason why kids have a shunt is post-hemorrhagic hydrocephalus of prematurity. And again, those kids almost always end up needing their CSF diverted when they're very young. And so as a result of that, they really depend on their shunts, and they can present with acute decompensation as well, because, I think that when their body is sort of used to all the CSF going down the shunt, when that stops, it can be really sensitive. So that's a really good one. Date of last revision is also really important, and that's something that I always ask when somebody calls me with a potential shunt malfunction. The reason for that really has to do largely with infection. It has to do with two things, but infection is the big one. And that's obviously the bugaboo that all neurosurgeons despise about shunts. And during the first 6 months or even the first year after a shunt, the index shunt operation, whether it's a revision or an initial placement, the index of suspicion for a potential infection is much higher. So if someone had a shunt revision 3 weeks ago and they come in with a fever and looking crummy, my concern for an infection is fairly high, and I'm probably going to want to tap that shunt and get some fluid. If they last had their shunt instrumented or worked on 3 years ago, my index of suspicion is going to be extremely low. And I would probably not recommend doing a shunt tap or anything, because it's almost certainly not the source of that same fever or irritability in that patient. So that's really important in terms of, that's why the timing thing is important. And also, a fair percentage of shunt malfunctions do happen in the first like 20 to 30 days after a shunt operation. Just so that's not an infection issue, that's a malfunction issue. The next thing you said was the head circumference and the fontanelle tension. And those, again, are really important. As, obviously, like you mentioned, in babies. So as you get older and your sutures fuse, your head can't expand anymore and you don't have a fontanelle. But in the young ones, for sure, those are really good clinical indicators of high ICP. And so in a kid who may be at risk for developing hydro, or in a kid who already has a shunt who's obviously at risk for a malfunction, those exam findings are important. One of the things to keep in mind is when a baby is irritated, when they're crying, when they're laying supine, it's very normal to have a full fontanelle. And so you really want to examine it when they're calm, when they're upright in their parents' arms or something like that, if you want to get a really good, reliable exam. And when it comes to the head growth, obviously just measuring the head circumference is good. You can also check the sagittal suture. You can put your finger on there. And if you can feel a gap between the parietal bones that's more than your finger breadth usually, then that's a pretty reliable physical exam finding among different examiners that maybe the pressure is a little bit high. And again, that's not always the case, but it's a useful, really quick and dirty check if you're feeling a kid's head in the ED. So I think those are really good things to bring up as tools for the initial evaluation of a kid with a shunt for a rule out shunt malfunction. And fluid collections along the shunt tract are another really good one, especially in young kids and also sometimes in teenagers. In the young kids, they have so little soft tissue in the scalp and it's pliable enough, like a Shar-Pei, that the fluid can track around the shunt and then down along the tract on the outside, and then it can become palpable under the skin. And certainly that can be an indicator of a shunt malfunction and that the fluid's just finding its way around. So that happens more in young kids. As kids get older and the scalp gets thicker and stronger, the fluid can't necessarily dissect along the scalp as well as it can in a baby. In sometimes teenagers, especially with catheters that we used to use for the distal catheter that goes from the valve down into the peritoneum, those catheters are sometimes have barium impregnated in them throughout the circumference of the catheter so that they're easier to see on X-ray. Those catheters over time can react with the skin and sort of scar in. And then as the child grows, it pulls from above and below and it can pop. And when that happens, if the shunt is still working, fluid will flow into that open space where it's popped. And so you may see a fluid collection in the neck or near the clavicle, which is the most common places where that happens. So in the baby, you can see fluid along the tract. And then in like an adolescent or a teenager who's done some growing, you can see it as well. So that's relevant in a couple of different contexts, and then, the other thing, one thing that's kind of like a nice, I think, rule out for the shunt is GI symptoms sometimes. So neurosurgeons love diarrhea. And the reason is because shunt problems almost never present with diarrhea. So you have a kid who comes in with fever and vomiting and you're worried they have a shunt problem. When they also have diarrhea, it's much less likely that that's a shunt problem. And so that's one of the things that sometimes we use as like a little bit of a rule out. Not that that's a red flag, but it's just kind of a relevant thing we think about. And then seizure is kind of an interesting one. Generally speaking, teaching among pediatric neurosurgeons is that seizures are not a manifestation of a shunt malfunction very often. Every so often we'll see it, but it's not super common. And so I think obviously knowing about a seizure is really important and managing it safely. But generally speaking, when someone presents with a seizure, I don't immediately jump to that being a shunt malfunction the way I do with some of these other things.
All right, very good. So I hear, those are excellent advice and very important details for us pediatric emergency doctors to know. One of my take-home points from what you said is, and please correct me if I'm wrong, is the younger the child is when he or she got the shunt, the more worried I should be. Is that right?
Yeah, I think that child is just a little more likely to present with a more dramatic presentation. So even, the vast majority of kids who present with a shunt malfunction, even if they got their shunt placed when they were an infant, will still present with a relatively slow moving thing, worsening headaches, some vomiting. It's not like they have to get immediately rushed to the OR. But among the ones who do, it seems like usually those are ones who had a shunt placed really early in life. And it's not just the IVH of prematurity and myelomeningocele. It can also be a patient, for example, with aqueductal stenosis, who has a congenital reason and got their shunt placed early. It's just that they're at risk for it. It's not that they always do it, but I do. When I know a kid got their shunt placed really early in life, I certainly pay attention to make sure that we're not missing something.
Very good. So again, excellent information for us PEM clinicians. The next question I wanted to ask you, and I wouldn't fault you if you ever listen to my podcast, because neurosurgeons are not supposed to listen to my podcast. But one of my favorite rules that I speak about in my podcast is rule number 4: less is more. And my experience with regards to neurosurgery and head trauma, very often I see patients, specifically newborns, with head trauma. I do the CT because of the age. I diagnose a skull fracture, and both in Pittsburgh and in Florida, where I used to work as a fellow, as an attending, skull fracture would have to be admitted. Oftentimes, even if the child is clinically well, we'll have to go to the PICU. And my anecdotal experience that the next day the neurosurgeon will see them, say hello and goodbye, and they would be discharged. And I understand from you that there's some new information that all of this may not be necessary. Can you tell us about that?
Well, yeah, I mean, I think that there have been a couple of algorithms that have sort of come out looking at this idea that every kid with a linear non-displaced skull fracture needs to get admitted, much less to the ICU. And I think your observation is exactly right. We have kids, working in Colorado, we'll have kids who get air flighted in from 2 states away, just so that we can say, yeah, this kid should go home now. And so that's really something that is incredibly inefficient and frustrating for the families and the providers. And obviously it's incredibly expensive and not a great use of resources. So there's a lot of interest in trying to parse out, who really needs close attention, who's likely to develop progression and who doesn't. And in work from, and this isn't necessarily stuff that's been published yet, although I think it probably will be before too long. But I know a couple of different institutions, including ours, where we've done QI projects looking at all of our linear non-displaced skull fracture patients who they don't have any significant amount of blood in the head. So they may have a goose egg on the surface, but there's not a lot of displacement. They are obviously at their neurological baseline. So whether it's GCS 15 or in an infant, 13 or however you want to, categorize it, those kids will basically never need neurosurgical intervention and almost never have any type of significant complication. And so most of those kids can certainly get observed in the ED we do between 6 and 8 hours at our institution. And we still consult on most of them, but our most recent algorithm is actually working with RED to say, hey, if they meet these criteria, you probably don't need to call us, and they probably don't need to follow up with us unless you have any question or there's any, intracranial blood or anything like that. And there's a recent really interesting project looking at fast MRIs versus CTs for those patients to try to decrease the radiation burden, and that really anything of any clinical significance you'll be able to identify on a fast MRI scan, even though it's hard to see the fracture itself. It turns out that that's clinically not super important in terms of their prognosis. So that's like an interesting little thing for places who have really ready access to a quick brain MRI sequence. And, the last thing that we worry about with those kids is, are they going to develop a growing skull fracture? So down the road, that comes, or the other term people use that as a leptomeningeal cyst, where over time that fracture doesn't heal. And because of an occult underlying dural tear, CSF pressure pushes it open, and you end up with a larger fracture over time that needs surgery to fix that. It turns out that the kids who have just a linear fracture, that's a fairly, simple one that doesn't bridge all the way, for example, from the coronal suture to the lambdoid suture, almost never develop those. So the ones who have a complex fracture that has multiple sort of branch points or that connects two different bones, they probably need to at least be followed up in the outpatient clinic for neurosurgery. But the ones who have just a simple linear one, which is the majority, probably don't even need that.
Okay.
Yeah.
So maybe I was right all along. Rule number 4, less is more. That's
I think
great.
rule number 4 sounds good. Yeah, my father's a doctor, and that's what he used to say is, especially with spine, less is more.
Less is more. Perfect.
Yeah.
When maybe we can save some PQ admissions for some unlucky children.
For sure. And I want to be respectful of the fact that at places that have a really high volume of kids, or that's all they do, it's really easy to be flippant and say, hey, that kid can go to the floor. Hey, that kid can stay in the ED. In places where that's a less common thing, I don't disparage anybody for being careful and putting the kid in the ICU or watching him a little more closely. So,
sure. Yeah, good point. Thank you for saying that. Todd, thank you so much for coming on the show. This was super helpful for us, PEM clinicians and PEM physicians. As always, I'd like to honor you with an outro of your choice. And I'm going to do my best, but I understand you like Beastie Boys.
Yeah, man, they're great. Yeah.
Let me guess.
I appreciate it.
You were a teenager in the 90s.
There you go. I know it's funny. You can always tell in the OR when we're picking music, like how old people are by what music they pick, because it's always like 90s stuff when you're my vintage.
I'm not surprised. So in your honor of coming on the show, as you requested, I'm going to do Sabotage by the Beastie Boys.
All right. Hey, thanks a ton, man. This was really fun. I really appreciate it.
Thank you, Todd, for coming on the show. Appreciate your time and your great advice. Thanks a lot.
You bet. Have a good one.
And that is it for today, guys. Thank you very much for listening to PEM Rules. Thank you for supporting PEM Rules. Thank you for reading my articles on EP Monthly. And please, if you have an interesting patient or you apply the rules in your clinical work in any ways, please don't hesitate and you can contact me through the website and I'd love to have a discussion with you about it. This is Sabotage by the Beastie Boys. Not an easy song to play. There's a lot of mess there that you have to mute. Todd, I hope you like it. Have a great day, everybody. Thank you for listening.